ఓకేనా? రేటింగ్ పెద్దదనుకో.
లాస్ట్ కదా ఫ్యాన్. వాడు చెప్తున్నాడు వాడు చూడరా అంటే కూడా చూపించాడు, ఇంట్రెస్ట్ చూపించాడు.
హలో, స్టార్ట్ అయింది.
కో-హోస్ట్ ఎట్లా చేయాలి?
అదంటే ఇద్దరు హోస్ట్ అంటే ఎట్లా చేయాలి?
కో-హోస్ట్
రైట్ క్లిక్ ఎవరి మీద చేయాలో వాళ్ళ మీద రైట్ క్లిక్ చేయాలి. ఓకే.
ఆ రెడ్ చూపించేది ఆడియో అంటే మ్యూట్ కొట్టడమా?
ఆడియో అంటే
మ్యూట్ చేయడం అంటే మ్యూట్.
మాట్లాడొచ్చు కదా. అవును. యా ఓకే. సరే, ఎవరైతే ప్రెజెంటర్ ఉంటారో వాళ్ళని అన్మ్యూట్ చేయమన్నాడు, లేకపోతే మీడియాని మ్యూట్ చేయమన్నాడు. నువ్వు ఇంకో హోస్ట్ కావాలన్నది ఎవరిని కో హోస్ట్ చేయాలనుకుంటున్నావు వాళ్ళ దాని మీద కర్సర్ పెట్టి రైట్ క్లిక్ చేయాలి.
Allow participants to unmute themselves. No.
ఇంతమంది వచ్చింది. అవును, నీకు ఏం చేయమంటావు?
ఇన్వైట్ ఏం చేయమన్నాడు? కర్సర్
ఇన్వైట్ కాదు, ఎవరినైతే కో హోస్ట్ అనుకుంటున్నావో వాళ్ళ పేరు మీద పెట్టి రైట్ క్లిక్ చేయమన్నాడు. నీకు వస్తుంది అంట కో హోస్టా ఇంకోటి ఎవరు, ఏది కావాలో అది క్లిక్ చేస్తే కో హోస్ట్.
రైట్ స్టార్టింగ్. వందన పెట్టింది జాయిన్ అవుతుంది. ఇదేంటి రెంటికల్ ఇట్లా పెట్టుకోండి పైకి. ఇన్వైట్ ఏంటిది?
ఇన్వైట్ నీకు ఎందుకయ్యా?
మేక్ పోస్ట్ అర్థమైంది. వీడియో ఇస్తున్నప్పుడు అన్ని నుంచి ఒక 30 సెకండ్స్ ఏమన్నా అడుగుతుండే. స్టార్ట్ అయింది. హలో సార్.
హలో
హలో సార్.
హలో
సార్ చెప్పండి.
హలో
లక్ష్మణ్ సార్ వింటున్నా. వినపడుతుంది. వినపడుతుంది సార్.
మరి మేడం వాళ్ళు రెడీగా ఉన్నారా?
మేడం రాలే, జాయిన్ కాలే. మేడం రాలే. 6 o'clock వస్తుంది మేడం.
ఓకే ఓకే,
వాళ్ళు రాగానే అడ్మిట్ చేసేస్తా.
అయితే నేను నరేంద్ర కుమార్ సార్ తో మాట్లాడాను ఇప్పుడే. హలో
చెప్పండి.
సో లుకింగ్ బియాండ్ యూటీఐ అని చెప్తానంటున్నాడు.
ఎవరు? నరేంద్ర కుమారా? మరి మీ బాస్ ఆయన? మరి ఈయన
బాస్ కుదరదట,
భువనేశ్వర్
చేస్తానంటున్నాడు. భువనేశ్వర్ కుదరదు, ఆయన కుదరదు అంటున్నాడు.
ఇంకో అమ్మాయి ఉంది అక్కడ, పీడియాట్రిక్ సర్జరీ. ఆమెను అడుగుదామా మరి?
ఎవరు?
మందాకిని అన్నా లేకపోతే జ్యోతి బాత్రా అని ఉంది.
నరేంద్ర కుమార్ సార్ తో ఇప్పుడే మాట్లాడాను, ఒక నిమిషం ముందు మాట్లాడాను. ఆయన చెప్పాడు, నేను కట్ చేసిన, నువ్వు పిక్చర్ లోకి వచ్చావని నేను కట్ చేసి నేను 8 o'clock మాట్లాడతాను సార్ అని చెప్పాను.
అదే మాట్లాడినాక అప్పుడు మనం డిసైడ్ చేద్దాం మరి.
నేను 8 o'clock మళ్ళీ మన మీటింగ్ అయిన తర్వాత 8 o'clock మాట్లాడతాను. యాక్చువల్లీ నేను ఆల్రెడీ భువనేశ్వర్ చెప్పింది ఏంటంటే ఇద్దరు కావాలని.
ఇద్దరైతేనే బాగుంటది.
అయితే ఎవరు అంటే ఒక లుకింగ్ బియాండ్ యూటీఐ అంటే ఓన్లీ యూరినరీ ట్రాక్ట్ గురించి చెప్తాడేమో. మనకు అన్ని టాపిక్స్ మీద కవర్ అయ్యేటట్టు చెప్దాం, అడుగుదాం.
లేదు, అన్ని టాపిక్స్ చేద్దాము, ఎందుకంటే పీడియాట్రిక్ సర్జరీ డౌట్స్ ఉంటాయి కదా అందరికి.
అవును.
సో డౌట్స్ ఉన్నప్పుడు పీడియాట్రిక్ సర్జరీ పిలుస్తేనే బెటర్.
మనం అట్లనే చేద్దాం. నేను అదే అడుగుతాను. నేను ఆయనని కట్ చేశాను సార్, నేను కట్ చేస్తున్నాను, 8 o'clock మాట్లాడతానని చెప్పాను. మోస్ట్ ప్రాబబ్లీ పీడియాట్రిక్ సర్జరీ ఆన్ వెడ్నెస్డే.
మరి మండే ట్యూస్డేనేమో మురికి. హలో,
ట్యూస్డే మురికియా?
ట్యూస్డే మురికి.
చెప్పండి.
నెఫ్రాలజీ ఏమో
మండే ట్యూస్డే వెడ్నెస్డే కంటిన్యూ బాగుంటుందా? మండే పెట్టేసి పీడియాట్రిక్ సర్జరీ థర్స్డే పెడదాం. థర్స్డే
ఇక వచ్చిన వాళ్ళే పెడదాము, రానోళ్ళే వదిలి పెడదాము. మనం ఎట్లా కొన్నాం కదా.
ఓకే రైట్.
28th రోజు 28th మే థర్స్డే.
28th థర్స్డే.
సంజయ్ రాసుకో.
డాక్టర్ సంజయ్,
సతీష్ తివారీ అమరావతి, మహేందర్ రెడ్డి కామినేని, తర్వాత రమేష్ కంచర్ల రెయిన్బో.
అందరూ ఒక్క రోజేనా?
ప్యానల్ డిస్కషన్ అది.
రమేష్ కంచర్ల. ఓకే.
మేడం వచ్చినట్టుంది, అడ్మిట్ చేయనా?
అడ్మిట్ చేసి.
నేను కోహోస్ట్ చేస్తా. మరి నేనేనా కోహోస్ట్?
ఎవరు? నువ్వే ఉండు.
నేను ఉంటాను, నాతో పాటు నువ్వు కోహోస్ట్ ఉండు.
ఓకే.
ఇదే ఒక్కసారి మళ్ళా కనబడతలేదు అంతా. ఏమవుతలేదు. సార్ ను పార్టిసిపేట్ చేద్దాం, లక్ష్మణ్ సార్. Sir, Lakshman sir, president. ఇక్కడ బకుల్ జయంత్ వస్తున్నాడు మన బాబు లక్ష్మణ్ సార్.
యా
బకుల్ సార్ వస్తున్నాడు,
చెప్పండి.
బకుల్ సార్.
I will just join you to say hello.
Yeah sir,
Good evening sir. Good evening.
Welcome.
I should promote your activities, no? That's why.
Yeah.
Yes sir. Sir, welcome to
Bakul
our
sir.
Thank you Dr. Lakshman, Dr. Yashwant. Thank you very much.
Yes sir. Sir, Bakul sir, I think you are very, very busy in conducting so many webinars.
I'm attending all the webinars so I can appear for MD exams. I have not been able to attend any scientific session during my last 10 years being an administrative post every time. So this is the first time I'm listening to everybody for last 1 month.
Yes sir.
So how are things going on, Yashwant? I think you have every day some webinar,
Yeah,
right?
fine sir.
Yeah.
Yes sir. Every day we are having
Yeah.
sir. TCB.
Hi Gopal Singh.
Sir, good evening sir.
Good evening.
Sir. Namaskaram sir, Lakshman sir.
Yeah, namaste Gopal Singh.
Sir, namaskaram.
Yeah, welcome Sirisha ma'am. Welcome. Hello ma'am.
So Yashwant, I will leave now because I thought I'll just join and say hello to all of you. Okay.
Hello sir, good evening sir.
Good evening. Dr. Lakshman.
Hi ma'am.
Yashwant, I'll take your leave.
Yes
Yeah,
sir.
sir.
Okay, sir. Thank you very much sir. Thank you very much.
Thank you.
Thank you.
Ma'am. Dr. Lakshman.
Sir, Dr.
You can start. Madam is coming.
Sir, the small problem, actually there is no power at home. Through hotspot I have connected, so I shouldn't get a call. If I get a call, there will be some disconnection again.
Madam, no
it
problem,
will
no issue.
log in again.
Okay, what about madam? What about the other madam?
Sandhya
madam?
Pooja.
Hello sir. Dr. Bhaskar garu.
Hello, good evening, sir. Yashwant garu.
Good evening, sir. Good evening.
Pooja Nivitra.
It's not clear. Sir, are you going to introduce?
Yes, madam. Another 2 minutes.
Okay.
Yeah, we will
So,
start exactly at 6 o'clock, madam.
Sure. Yeah. So first, Dr. Sandhya will speak about like approach, initial theory part. Then I will do the question.
Change. Okay, what is schedule? Okay.
Yeah.
Dr. Sandhya will come first.
Yeah, Dr. Sandhya will speak first.
Okay. So, good evening, everybody. Welcome to our webinar. I am audible. Hello. Dr. Yashwant? Dr. Yashwant?
Yeah.
I'm audible?
Yeah, I'm audible. You are audible, sir.
Welcome to third webinar. Good evening, everybody. And today's speaker is Rainbow Hospital. V. Sandhya, consultant hemato-oncologist, Rainbow Hospital. First, we'll take over to Dr. Yashwant for introduction. Thank you. Yashwant, take the mic.
Yeah. I welcome. It is indeed a great honor to introduce Dr. Sirisha madam.
చిన్ని నాకు ఇయర్ ఫోన్స్ ఇవా అది ఉన్నది నాన్న తలకాయనికి
Hello. Yeah, we'll start the program, ma'am. Yeah, ma'am. Dr. Siri, Karnool Medical College. She did her MD Pediatrics from PGI Chandigarh. She was the best student, outgoing student from PGI Chandigarh, and has been in Rainbow Hospital since she joined Rainbow. Her specialties of interest are acute leukemia and malignancies. Your attention to Dr. Sirisha, madam.
Hello.
Ma'am, take over, ma'am.
Yeah. So hi. Good
Yeah, ma'am,
evening
take
all.
over.
So as we all know, bleeding child is always a important topic when we are discussing about pediatric practice in our day-to-day regular pediatrics. So to begin with, I introduce our consultant pediatric hematology oncology college, and then she completed her fellowship in pediatric hematology oncology and BMT. And currently she is joined as a consultant in the hospital along with me. So Dr. Sandhya will give overview like how to approach to begin with, and then I will take you through various case scenarios. So over to Dr.
A very
Sandhya.
good evening to all. I'm Dr. Sandhya V, Junior Consultant in Pediatric Hematology and Oncology at Rainbow Children's Hospital, Hyderabad. Today I would be speaking about approach to a bleeding child. Bleeding is a very common presenting symptom in pediatrics, and it is a diagnostic challenge because a wide range of conditions can cause bleeding in a child. Specific diagnosis is very important clinically to initiate appropriate therapy as well as to take precautions to prevent bleeding in the future. Before going into common bleeding disorders in children, I would just like to go through hemostasis process quickly. The process of hemostasis in our body consists of three important phases. The initial is the vascular phase. Immediately post injury, the vessel undergoes vasoconstriction. The platelet phase, where the platelets undergo adhesion and aggregation to form a primary hemostatic plug. And then on top of this primary hemostatic plug, the coagulation cascade starts, where the coagulation factors undergo sequential activation to form a stable fibrin plug. This is an overview of the coagulation cascade. It shows both the extrinsic and the intrinsic pathway. As you all know, it consists of factor 7, whereas the intrinsic pathway consists of factor 12, 11, 9, 8, etc. Common pathway is important because it consists of factor 10, factor 2, factor 1, and this is common to both the extrinsic and the intrinsic pathways. Excellent. Any of these factors may lead to a coagulation disorder. Just to go for a recap, these are the coagulation factors and their names that are found in the human body. Coming to the type of bleeding disorders in children, this can be classified in various blades, commonly as inherited or acquired, or based on the underlying etiology as platelet disorders, coagulation disorders, mixed disorders with features of both platelet and clotting problems, and also vascular disorders. Vascular disorders are comparatively rare in children and include Phenol-Schönlein purpura, connective tissue disorders, and vitamin C deficiency. Platelet and coagulation disorders are what we commonly encounter in our outpatient department. Platelet disorders can be classified into quantitative disorders where the number of platelets is less and qualitative disorders where they're functionally deficient. Quantitative platelet defect, that is thrombocytopenia, is most commonly an acquired condition with underlying cause like infections or disseminated intravascular coagulation, immune mediated, that is immune thrombocytopenic purpura or ITP, hypersplenism or other consumptive causes, mechanical platelets that is like a hemolytic uremic syndrome or thrombotic thrombocytopenic purpura, drug induced, and very importantly, infiltrative marrow disorders like acute leukemia or secondary from a solid tumors. These can initially present malignancy. Inherited causes of thrombocytopenia are comparatively rare, and these include marrow failure syndromes like Fanconi anemia or isolated platelet failure syndromes like congenital amegakaryocytic thrombocytopenia absent radius syndrome, TRUS, dyskeratosis congenita, etc. Certain immunodeficiency syndromes like Wiskott-Aldrich syndrome or X-linked thrombocytopenia may also present with thrombocytopenia initially, and they will have other features of immunodeficiency which may help us make an accurate diagnosis. Coming to platelet function disorders or qualitative platelet disorders, these are predominantly inherited, and important of these are Bernard-Follier syndrome, Glanzmann syndrome. These are defects in the platelet surface receptors which lead to defective adhesion and aggregation of platelets. Other conditions like platelet storage granule disorders like Hermansky-Pudlak syndrome, MYH9 associated disorders, leukocyte adhesion defect type 3 are very rare. Von Willebrand disease, that is due to qualitative or quantitative deficiency of von Willebrand factor in the body, can also be considered under a platelet functional disorder because it is required for the proper functioning and adhesion of the platelets to the subendothelial tissues. Rarely, certain acquired conditions may also lead to functional deficit of the platelets. Important is drug induced, like usage of antiplatelet drugs, and also renal deficiency or renal defects leading to uremia. Coagulation disorders is what we commonly encounter with severe bleeding in our OPs. These include inherited conditions like hemophilia, hemophilia A, B, or C. Hemophilia A is due to deficiency of factor 8, hemophilia B is due to deficiency of factor 9, and hemophilia C is due to deficiency of factor 11, and it is very rare. Other factors may also be deficient, leading to hypoprothrombinemia, hypo or afibrinogenemia, factor 5, 7, or factor 10 deficiency, factor 13 deficiency, von Willebrand disease, etc. Rarely, there is a system known as the antifibrinolytic system, which keeps a check on the fibrinolysis, that is the breakage of the clot. If there is any deficiency in factors of the antifibrinolytic system, like alpha-2 antiplasmin or plasminogen activator inhibitor 1, this may also lead to excessive bleeding following minor trauma. Rarely, we may see acquired causes of coagulation disorder. Common in neonatal period is vitamin K deficiency. The conditions here include liver disorders, usage of anticoagulant drugs, PIC, that is disseminated intravascular coagulation, or massive transfusion syndrome following road traffic accidents, malignancy. Interestingly, Wilms tumor is a renal malignancy which may lead to acquired von Willebrand disease. These children initially present with bleeding and later on are detected to have a renal mass. Coagulation inhibitors are very rarely encountered, and usually they have an underlying inherited coagulation disorder. So the main topic today would approach to diagnosis of these bleeding disorders. Very important in the approach and initial step is a complete history. In the history, we need to see the age of onset of the condition. Usually inherited or bleeding disorders present very early in life, sometimes during the neonatal period and early infancy also. Gender is essential because some of the bleeding disorders are X-linked, predominantly, most commonly is hemophilia. So these are present only in the males, and females are essentially the carriers. So it is important to see whether a male or a female child is affected with a bleeding disorder, which will help us rule out some of the conditions. Predisposing events are important because sometimes children will have bleeding without any underlying cause. Minor bleeding is common in children. So if there is a bleed with minor trauma or spontaneous bleed, that is indicative of an underlying bleeding disorder. Drug history is self-explanatory. Past history of recurrent bleed indicates towards a significant bleeding disorder, which can be inherited or acquired, but a positive family history points towards an inherited bleeding disorder. On examination, we need to see the type of bleed and also the site of bleed. Platelet disorders of platelet usually present with superficial skin and mucosal bleeds. They may present with epistaxis or bleeding in the stool like melena and oral mucosal bleeding spots, skin spots. Whereas coagulation disorders usually present with deep-seated bleeds, like hemophilia will present with intra-articular, that is joint bleed, or intramuscular bleeds. Presence of other conditions like organomegaly or lymphadenopathy indicates towards presence of a systemic disorder like a malignancy. We need to also see the child as a whole to look for any physical features that may indicate towards a syndromic condition. Here is a table which is showing certain clinical anomalies associated with inherited bleeding disorder. This table is not complete, but does show the important conditions. For example, absent radius, that is skeletal difference of excessive eczema in a case of Wiskott-Aldrich syndrome. Then investigations form an important part of management of bleeding disorders. And the first and foremost investigation is a complete blood count, including the platelet count as well as the peripheral blood smear examination. If the platelet count is low, it straight away points towards a quantitative platelet disorder. If platelet count is normal, we need to see the peripheral blood smear carefully. It gives us an idea about the morphology of the WBCs to rule out any malignancies. Also, the morphology of the platelets. There are certain morphological changes in the platelets which may indicate specific conditions, like presence of very small platelets. Microplatelets is indicative of Wiskott-Aldrich syndrome, which is one of only syndrome with very small platelets. Presence of large platelets may indicate immune-mediated destruction of platelets, like in ITP. Whereas presence of giant platelets is almost diagnostic of Bernard-Solier syndrome, which is a platelet function defect. Other conditions other investigations like renal function test, liver function test will be required to rule out a systemic condition, and bone marrow examination may be needed to rule out an infiltrative marrow disorder. If the platelet count is normal, we go for coagulation screening tests, that is prothrombin time and activated partial thromboplastin time. Prothrombin time is deranged in extrinsic pathway defects, which include factor 7, and also in common pathway defects, whereas APTT is deranged in intrinsic pathway defects and common pathway defects. Mixing studies and factor assays form the next step, where you can see in cases where there's a deranged PT or APTT. This will give us the definitive factor that is deficient. Urea clot lysis test was done previously for factor 13 deficiency, but now quantitative and qualitative assessment of factor 13 is available, so this test is not performed. bleeding time by IV's method better or by Duke's method is a screening test for the platelet functions. If the BT is prolonged in the presence of a normal platelet count, it is indicative of a platelet functional defect, which can be confirmed by doing platelet function tests. This platelet function test can be done either by aggregometry or by flow cytometry, the detailed description of which is out of context here. The final diagnostic thing would be a genetic mutation analysis in cases of inherited bleeding disorders. This is a simplified flow chart which shows the initial screening tests like PT and APTT. Based on this, and also this table which is showing a tabular description of the same flow chart, here based on the general condition of the child, whether it is well or sick, the bleeding time, the PT, the APTT, and the platelet count, we can reach an accurate diagnosis, which can later be confirmed by doing specialized investigations. This is a rather busy slide, which is showing an overview of the management of common bleeding disorders in children. In case of life-threatening bleed, the priority is stabilization with blood products. But if possible, before giving blood products, it is always prudent to collect blood samples for investigation so as to reach an accurate diagnosis. For platelet disorders, the treatment is chiefly platelet transfusion, except for in cases like immune-mediated destruction, ITP, where steroids and other immunosuppressants play a more important role. Coagulation disorders can be managed with factor replacement where available, or if factors are not available, we give FFP or cryoprecipitate. Acquired conditions, the dictum is always treating the underlying cause along with the supportive care. Other medications like tranexamic acid helps in the supportive care of children with inherited bleeding disorders, where it can prevent minor bleeds. Though in case of major bleeds, we may have to give proper factor replacement. Prophylaxis is important for inherited coagulation disorders like hemophilia. If a child with hemophilia is getting into recurrent bleeds, it is prudent to put them on weekly prophylaxis, twice or thrice weekly prophylaxis of the factor so as to prevent long-term morbidity. Last but not the least is genetic counseling. In cases of inherited bleeding disorders, it is highly essential to do the genetic mutation analysis in the index child and also counsel the parents regarding antenatal diagnosis during the next pregnancy so as to prevent the birth of a child with a major significant life-threatening bleeding disorder. Thank you for your patient listening, and I'll be happy to take any questions at the end of the presentation session.
Thank you, Sandhya.
Thank you. Over to Dr. Sirisha, ma'am.
Thank you, Sandhya, for lucid presentation on the hemostasis and importance of history and clinical examination, and then how to analyze investigations once we arrive at our clinical diagnosis. So now we'll move on to case scenarios.
Hey, baby, you share yesterday?
Yeah.
So yeah, we'll go through various clinical scenarios as Sandhya has already given the overview on all these coagulation cascade approach and investigations. I'm not going through that. So we'll directly go to the clinical scenarios. As we all know, initially we always think, is it acquired or inherited? And once we know whether it is acquired or inherited, second question that comes to our mind is it a platelet disorder or are we looking at a clotting disorder? So among platelet disorders, once again, it is based on the age. We can approach the child differently. First, let us look at the neonate. Before I start, can I request you to mute your microphone, please? Please mute your microphone. Let us look at neonate. This is a term CKG boy by fetal delivery, double hematoma on date of supply, and he was born healthy, but he has physical problems and other platform is normal. Patient baby had to take care of babies hemoglobin, WB potential count are normal, platelets are normal. The cause of bleeding is platelets are basically low, and that is the reason for saprophtoma. What is the reason for low platelets? Madam, in a well child, otherwise with normal clinical examination, no maternal factors that suggest low platelets in the baby. We always look at immediate. So when you
Sir, Yashwant sir.
Yeah.
born baby with severe we will see to the tune of 10,000, 20,000. Normal, but
Dr. Pavani is there.
What do you feel? The way we treat need immediately maternal go ahead and replace the this kind of scenarios where baby gets affected or even conditions. Even a native baby who dies in the stage of need has to require even intracranial bleed and manual separate accordingly to the
Speaker. Sirisha, madam. Sirisha.
see in a bad mood. So we have to counsel them in case the baby is requiring any vacuum or forceps. Avoid that. Prevent intracranial bleeds in the second pregnancy and go for cesarean section. So those kind of counselings are mandatory in these children. So this the previous case was ours, but this is a downloaded picture just for education purpose. This is a preterm baby who comes with a rash like this. Nowadays, it is extremely rare with severe thrombocytopenia, not very severe thrombocytopenia like less than 20,000, but 30-40,000 severe to moderate thrombocytopenias. One has to suspect congenital infections like CMV and rubella. And of course, we also always have to remember that generally it doesn't require any transfusion unless otherwise they are in the bleeding phase. And this is another condition, that is maternal lupus also can have moderate thrombocytopenia, and that also resolves over a period of time as it is another immune mediated condition secondary to maternal lupus. So let us look at and other than that, as Dr. Sandhya highlighted, in the younger age group, one also have to think of conditions like Wiskott-Aldrich syndrome. We have seen kids presenting at very early age, like within 6 months of age, presenting with recurrent diarrheas or sometimes they even infections like pneumonias, and then found to have very low platelet count. And during diarrhea phase, they also had hematochezia. So indicating, like even with a platelet count of 40-50,000, indicating there is some functional problem. So because Wiskott-Aldrich kids also can have defect in the dense granules, and then they can have bleeding even at moderate thrombocytopenia. So one has to remember these kind of differentials when you are looking at a young infant having bleeding at near moderate thrombocytopenia. So there, like, looking at the size of the platelets and bleeding time, those will clinch the diagnosis. Moving on to pediatric population. So this is 1.5-year-old child born to non-consanguineous parents, otherwise thriving well, presented with a 5 days history of petechia and bruises, and at the same time had dullness few hours prior to admission. And after admission, child also developed focal seizures. Had mild pallor on examination, oral and skin bleeding manifestations were present. Had severe thrombocytopenia in blood counts, mild anemia, whereas WBC and differential count are normal. Had giant platelets in the peripheral smear along with microhypochromic picture in RBCs. WBC morphology was normal, and MCV was low, RDW was high. So, and his bone marrow showed adequate megakaryocytes. First of all, we think like, 1.5-year child without any past history, coming with acute history. First question will come, is it acquired or inherited? Likely acquired, though the age is not very high, like it is just 1.5 years. So we can still keep it clinically inherited also as a second possibility, but history being acute, definitely acquired will come into picture first. So it's an acquired bleeding disorder, one, with severe thrombocytopenia, two, with giant platelets in the smear. So these 3 pointers indicates with normal clinical examination. Otherwise, these 4 points towards ITP. So bone marrow showed adequate megakaryocytes. 2019 American Society of Hematology guideline says if you have a clear-cut picture of the ITP, even if you don't do bone marrow examination and go directly for the steroids, it is provided you have peripheral smear showing giant platelets, normal WBC morphology, clear-cut clinical examination, and clear history towards ITP. Then one can go for the treatment of ITP even without bone marrow. However, as we all know, like looking at the smear carefully for WBC in all the fields, looking at immature platelet fraction. These two things may not be possible in many centers, especially in the periphery. Hence, for uniform practice, majority of us, like, all the pediatric hematologists in the country, generally we prefer to do bone marrow examination so that there will be uniform practice and no misusage of steroids. Hence, we do bone marrow examination and start the treatment. Here, as we know, like there is a dullness, focal seizures indicating intracranial bleed. Hence, ITP with IC bleed was diagnosed. So how do we manage? We are in a hurry here to improve the count. So at times when the ITP child comes in a stable situation, so majority of the times we do go ahead and counsel them to wait and watch, especially mild skin bleeds above 30,000 count. We do wait and watch. Whereas this is a severe scenario where IC bleed has happened. So definitely we are in a hurry to improve the count. So the best drug in this situation is in IVIG. And the only indication or the important indication to give platelets in ITP is IC bleed. So how do you manage? One is like drug that improves the count quickly, that is IVIG, and of course bone marrow also has been done. You can go ahead and start the steroids. And what is the incidence of IC bleed? As we all know, it is very rare. If you see 1,000 cases of ITP, you may come across 3-4 cases of IC bleed. So it is extremely rare. 0.1 to 0.3% incidence is the IC bleed in case of ITP. And of course, when you consider platelet transfusions in ITP, as we all know, only life-threatening bleeds like intracranial bleeds or massive GI bleed requiring even PRBC transfusion and causing hemodynamic compromise. So those kind of bleeds will require platelet transfusion, of course, in parallel to ITP management with the IVIG and steroids. Of course, IVIG we usually don't do give if there is no significant mucosal bleeds. One can treat only with steroids. So this is a acquired form of platelet number. Moving on to next case scenario. This is a 5-year-old boy born to consanguineous parents, presented with history of easy bruising right from 2 years of age. Recurrent episodes indicating that probably this is an inherited problem, and consanguinity probably point towards autosomal recessive. We don't know yet. And currently presented with epistaxis. Severe epistaxis required package, nasal packing to be done at local hospital, and then he came over to us. And he possibly swallowed the blood, so he had 2 episodes of hematopoiesis also at the same time, or mild amount of GI bleed. His platelets were normal at the time of presentation. Hemoglobin was low because of bleeding, and BT was prolonged in this child. PT and APTT and factor 13 were normal. So bleeding time prolonged, normal platelet count, and inherited disorder right from the beginning. So when BT is prolonged with a normal platelet, 2 things will come into mind. Is it like a platelet function disorder, or can it be von Willebrand's disorder? So in this child, von Willebrand factor was also normal. So definitely BT being prolonged in the presence of normal platelet count with a significant history suggestive of inherited problem, one has to go ahead and do the platelet function test. And then this child turned out to be, you can see the platelet function analysis picture. So turned out to be Glanzmann's thrombocythemia. So you do platelet aggregometry, and then you can arrive, or you can also go for the flow cytometry, and you can arrive at diagnosis. So Glanzmann's thrombocythemia is among platelet function disorder is a severe form compared to Bernard-Solier syndrome. And what are the differences? This is a severe form, that is milder form, and Bernard-Solier will have moderate to mild thrombocytopenia. Glanzmann will have normal platelets. Both will have prolonged BT. And as you can see in the next scenario, usually Bernard-Solier syndrome you see in girls. Not that it will not happen in boys. It's an autosomal recessive disorder. It can happen even in boys, but generally being a milder form, majority of the boys, they don't present with the clinical symptoms. So this is a girl, adolescent girl who presented with menorrhagia, and sister also had similar history. And if you ask for history, then further history, then she said like there is an excessive bleeding tendency right from early childhood as bruising, and with the sibling history and past history and consanguinity and menorrhagia, obviously one will think of definitely first thing we will look at is complete blood picture. In complete blood picture, platelets showed moderate thrombocytopenia of 82,000. Mean platelet volume is high. So here it is 12 with normal clotting, prolonged BT. So what is the diagnosis here? So as in the initial approach, Dr. Sandhya showed, it's a Bernard-Solier syndrome. So in Bernard-Solier syndrome, as I said, like, majority of the times it presents in adults and girls with menorrhagia. One has to think even von Willebrand's disease type 1 in these children, because but only thing that will differentiate the diagnosis, both the diagnosis is platelet count and mean platelet volume. So moving on to coagulation, of course, other than this, like there are many conditions like sepsis, DIC, and connective tissue disorders, malignancies, and all. So we'll see some of the scenarios later. Coagulation disorders. So in coagulation disorders, so as it has been already highlighted, so you have to think of intrinsic pathway defects, extrinsic pathway defects, common pathway defects. In intrinsic pathway defects, the factors has been highlighted already. In extrinsic pathway defects, so this is an example for that. This is a 4-month-old boy who has been born to consanguineous couple. So it's a recessive disorder possibly that points towards that. Presented with history of excessive irritability and right focal seizures. Young baby presenting with symptoms related to CNS problem, and this has evolved into status epilepticus. Baby had to go through antiepileptics and anti-edema measures, ICU care and all. And there is on further history, there is a history of hematoma formation post-vaccination at 1.5 and 2.5 months of vaccination period. And this child had right focal deficit because of the bleed shown in the picture, in CT picture. And there is a left frontoparietal bleed in CT scan. Blood counts are normal. Of course, there was mild anemia, but other than that, it was normal. PT was prolonged, significantly prolonged, but APTT was normal. As I said, like this baby received anti-epileptics and also FFP to begin with, and then came over to us, and there was a transient partial correction of PT to 28 seconds in between. And after that, again, 24 hours later, it has worsened again, back to 41 seconds. So what are the factor deficiency? If you recollect the pathways that have showed, so in extrinsic pathway, as it clearly says, it's factor 7 deficiency that comes into picture, which is once again autosomal recessive disorder. So we will go ahead and think in that line, and proceed to mixing experiments. And mixing experiments turned out to be severe factor 7 deficiency, which is less than 1%. So why there was a partial correction with FFP? Because it will not give you complete efficacy of factor 7 supplement in case of severe factor 7 deficiency. It will only do partial supplementation. Hence, there was a partial correction. Why transient partial correction? Because half-life of factor 7 is short, only 4 to 6 hours. So going by that, it got corrected transiently. Again, like after 24 hours, when it got repeated, then it has worsened again, and then factor 7 deficiency has been diagnosed. So what is the difference? One main difference what we have to notice between these inherited disorders and acquired disorders like vitamin K deficiency. Of course, vitamin K is both PT and APTT, both will be prolonged. Here only PT is prolonged. In acquired disorders like vitamin K deficiency, once they get into CNS bleed like this, you have given vitamin K, and of course in life-threatening bleeds like this, you also go ahead and give FFP. After that, rebleeding is unlikely because it got corrected with vitamin K supplementation. So rebleeding is unlikely. Hence, you see the baby developing normally in the follow-up, and then recurrence of bleed in the same place are less likely. So generally you see baby coming with normal development into the follow-up clinics. Whereas babies who bleed into the CNS with inherited factor deficiency like this, especially the factors like 7, where half-life is so short and requires aggressive supplementation, you do see rebleeds, you do see some residual disabilities. So these kind of things one has to expect in the future. And of course, being autosomal recessive disorder, we have to counsel the family for the future pregnancies. So this is just a picture to show you. In lockdown, one can try good art like this. So moving on to other factor deficiencies. This is a common factor deficiency, that is factor VIII deficiency. This is a young boy who was born to non-consanguineous couple, came with history of headache and vomitings and one episode of generalized tonic-clonic seizure. So there is no history of head injury, but very trivial trauma. He was sitting next to his younger sibling who pushed him, and then he has hit his head to the wall. So that much of trivial injury has triggered the bleed into his CNS, and then he developed the seizures and headache and vomitings and all, and found to have bleed in the CNS. Here, APTT is prolonged and maternal uncle suffers with bleeding problems. So this is an important clue for us. So when we are taking the history, obviously they don't come up with the history that maternal uncle has history of bleeding disorders, and especially when they are sitting with all the entire family. So that is a common problem what we always know when they have to reveal the complete details. So we have to go ahead and ask them the many maternal history of like uncles or grandparents, male members suffering with any bleeding problem. So then we can narrow down the possibilities faster, and APTT prolonged. Immediately one can go for the mixing studies looking for factor VIII or factor IX deficiency, because hemophilia is one of the common bleeding clotting disorder what we all face in our clinical practice. Factor VIII is more common compared to factor IX, and of course this child had factor VIII deficiency, and for this kind of scenarios also, one is manage the acute bleed with factor supplementation and put them on prophylaxis, as it has been mentioned in the previous talk. Though we counsel them for prophylaxis in severe cases, whoever get diagnosed early. So generally, like common presentation, as you know, they come with the joint bleeds. Most common joint is knee. So in childhood, they come with the knee joint bleed, and then you advise them to go for prophylaxis, but usually they refuse because of multifactorial. They don't want to go on to prophylactic treatment. But if you see scenario like this, like IC bleed, definitely we push them for prophylaxis, because you don't want another IC bleed to happen closely, and that can compromise many things, as we know. So mixing studies clinch the diagnosis in this child, and we have put him on prophylactic treatment with factor VIII. So we all know it's a royal disease. So this is a common bleed what we all see, that is knee bleeds in children. One has to be careful, like when a child comes, this top picture when says that like this child went to local pediatrician with acute febrile illness. They have tried sampling the child from elbow, the occipital fossa. When they tried taking the blood sample, he developed hematoma there, and then he developed compartmental syndrome. So he had residual weakness even at later age when he grew. So going by that, like we have to be careful if we or whenever we are sampling, like just basic history, if we take, we can avoid this kind of problems. And you may also see this kind of bleeds in the conjunctiva, and definitely no one wants to see this kind of x-rays where joint is completely damaged and then may require joint replacement, which is very big task in hemophilia children. So Hemophilia Federation of India provides factor at discounted prices for all these children, and then they can avail the facility at any time, even in the nights and all. And of course, luckily now under Arogyashri or in many hospitals like government general hospitals, factor is freely available, and kids are able to access for the free factor therapy. So moving on to other factor deficiencies. This is a young boy, 5 years, who came with short stature, learning problems, pectus excavatum, and HOCM, obstructive cardiomyopathy, hypertrophic obstructive cardiomyopathy. And this child was born to non-consanguineous parents by history. Came with tendency of easy bruising, notice right from 2 years of age. Once again, pointing towards probably this is an inherited problem, not an acquired problem. And this child also had progressive headache, vomitings, drowsiness, showed CT showing parenchymal bleed. So this is a downloaded picture actually, because child looked exactly same, but dad was not ready for clinical picture. So just for discussion purpose, I downloaded this picture. So he looked exactly same. Can anyone guess what is the diagnosis looking at the picture? So this child had normal platelet count, WBC, hemoglobin, everything was normal. PT and APTT were prolonged. So whenever PT and APTT are prolonged, what are the differentials one will think of? One is acquired causes like vitamin K deficiency, sepsis, DIC, liver disorders. So vitamin K deficiency is highly unlikely in this age group. Obviously looking at his age, and he was not coming into the picture of sepsis, DIC or liver disorder. So in inherited, what are the causes of prolonged PT and APTT? If you look at the pathway, of course, factor 1, factor 2, that is hypofibrinogenemia, dysfibrinogenemia, hypoprothrombinemia. These are the things that can cause, other than factor 5 and 10, which are more further rarer. So here PT and APTT prolonged. By history, this is probably inherited disorder. So, and this child had this kind of clinical picture. So he had clear features of Noonan syndrome. So he's a child with Noonan syndrome who are prone for hypofibrinogenemia. So inherited problems like hypofibrinogenemia or platelet function disorders. So both are described in these children. This child had hypofibrinogenemia. PT and APTT were prolonged. So in hypofibrinogenemia, one has to rescue them with cryoprecipitate and then treat aggressively IC bleed, and of course put them on prophylaxis for some time until they come out of IC bleed. So that is an example for factor 1, that is hypofibrinogenemia. And to let you know, hypofibrinogenemia is an autosomal recessive disorder, as some of you are aware, but this child was born non-consanguineous couple. So sometimes it happens, like even for non-consanguineous parents, we do see autosomal recessive disorders. And we have one family who are consanguineous couple, 3 kids are affected. Actually, after first child itself, we counsel them, but because of family beliefs and all, like they didn't want to go for antenatal testing, and all the 3 children, they have hypofibrinogenemia. They do come on and off with the bleeds, and then they get treated on and off for various bleeds. So this is another case scenario. This child is born to consanguineous parents, presented with history of multiple bruises right from 1.5 years, and at the time of presentation had painful bleed in the thigh. And she used to get into thigh bleeds every month, very painful. She cannot sleep at the night. So initially she got treated in the local hospital with FFP, and later she has come for further evaluation, and there is a history of sibling death with bleeding, and examination was otherwise normal. Here once again PT and APTT are prolonged, as we have just seen, like the potential for prolonged PT APTT in inherited problems. So you have a sibling death, consanguineous parents, and early age of onset, repeated episodes. Going by that, we know that it's an inherited problem. So other than factor 1, that is hypofibrinogenemia, other factors that can cause both PT and APTT prolonged is factor 2, that is hypoprothrombinemia. This child so factor 2 levels were very low. So we reported few cases with variable manifestations of severe hypoprothrombinemia. So this girl comes every month for FFPs. If she doesn't take once a month, though half-life of prothrombin is only up to 3 days, 2.5, 3 days, she after FFP she becomes clinically asymptomatic for 1 month, and again exactly after a month, usually she comes once a month for FFP transfusions. With that, her symptoms are under control. Otherwise, she gets into severe bleeding into the intravascular compartment. So moving on to other differential for prolonged PT-APTT, this is a common scenario. I'm not going into details of this. You are all aware of it. It's a gram-negative septicemia, which can lead to sepsis DIC. So what is the important thing we need to remember? Here one has to be judicial with the blood products. Don't treat the numbers, treat the child. So treat the bleeding child rather than numbers. Like if you are going for invasive procedures, or if the child is bleeding, then that is the time you need blood product support rather than treating the numbers alone. Next scenario, this is a HLA child. I'm not going into details, just to brief you, like even any infection like viral, bacterial, or connective
Sir,
tissue
audio రావట్లేదు.
all of them lead to coagulopathy in these
మీకు వస్తుందా?
children, develop secondary HLH, and that can cause bleeding manifestation. So now, though it was underdiagnosed in the past, now awareness is improving. day by day, and then more and more number of HLH cases are getting picked up, and then they are getting treated before they go into multi-organ dysfunction, because that is very important to treat them on time to prevent multi-organ dysfunction. So if you start treatment on time for secondary HLH, majority of them show excellent response, and then in secondary, definitely they don't get the recurrent episodes. Primary, of course, you will have some clues like, very early onset, age-wise, and CNS symptoms, family history, consanguinity. So this kind of clues will be there where it says that you have to investigate them further. So this is another case scenario. So we have seen like various factors like factor 7, 8, 1, 2. So, and then this is a case like girl child presenting with significant bleeding manifestations, recurrent episodes from early age, with severe pallor. When she came with the acute episode of severe hematemesis and epistaxis, her hemoglobin was 2. So she had a severe bleeding manifestations at the time of presentation, and her APTT was prolonged. So her hemoglobin was low for obvious reason that she was profusely bleeding. WBC DC platelets were normal. PT was normal. APTT is prolonged. So in a girl who has prolonged APTT with prolonged BT, so majority of us can guess the diagnosis, that is type 3 von Willebrand's disease. So whenever you see a girl, even in boys, like, whenever you see prolonged APTT, one has to even look at bleeding time. And of course, do we need to rule out type 3 von Willebrand's rather than labeling them straight away as hemophilia, because type 3 will have associated factor 8 deficiency. So factor 8 will be low in these children. Hence, we have to go ahead and check even either von Willebrand factor quantitative levels or antigen testing. One of them we have to do to differentiate between both, especially in a child who is in a girl child. So next scenario, this is a 1 month, 1 week boy who has born to consanguineous parents. This is first child. There is no family history of bleeding, either father or mother side. Came with history of prolonged bleeding post cord fall. Baby required PRBC transfusion and FFP in local hospital at 3 weeks of age, and then they discussed with us. We told them, once you give FFP, don't send them for evaluation immediately as long as the baby is stable. So they didn't come immediately. They came after 2 to 2.5 weeks. And then when they came, like, blood counts were normal. PT, APTT was, because baby was in post transfusion, so hemoglobin also picked up. PT and APTT was normal. Bleeding time was also normal. So when you have all the parameters normal, but you have a significant bleeding tendency that is requiring intervention with the blood products. So what is your diagnosis? I've written lower down just for, as we are not face to face to discuss the differentials. So as you can see, factor 13 is very low in this baby. So how do we manage? So once again, cryoprecipitate is rich in factor 13. So one can go ahead and give cryoprecipitate. But they're like, for availability, they have given the FFP, though they suspected factor 13 deficiency upfront, because that is one of the classical description. Prolonged bleeding post cord fall is factor 13. Of course, I want to say that that can occur in any of the inherited bleeding problems, but more specific for factor 13. So how do we manage? As I just mentioned, ideally cryoprecipitate, if not like FFP, so to stop the bleeding. And they can have a variable bleeding manifestation. They can have CNS bleeding or post cord fall bleeding. We have seen one child presenting even with the bleeding in the spinal cord, presenting with the weakness of the lower limbs. So they can have variable bleeding manifestations. Here also, once again, antenatal counseling is very important to prevent these kind of things happening in the future pregnancies, because this is an autosomal recessive disorder. So on the other hand, as we saw in the initial history and physical examination part, we all know that it is very important to look at the child in toto, look for proptosis, organomegaly, or other bleeding manifestations, fever, any gum hypertrophy. So this is a case that gives example for bleeding secondary to DIC in a case of AML. So especially APML. So acute promyelocytic leukemia, they are prone for DIC. So we have to be very careful in managing these children. Once we control this bleeding in the initial period, their prognosis is excellent. So they'll have very good prognosis. So we have to be very careful in handling them in the beginning. So this is, so just to see the, you can notice clear-cut ball tongue and prominent knuckle hyperpigmentation. So this is a 12 years old adolescent boy who presented with hematuria and easy fatigability and acute onset of, which is acute in onset, easy fatigability. So he, because of hematuria, he lost blood and he had severe pallor, mild icterus was there, mild splenomegaly was there. It was just felt. So here one will think like, is it like a hemolytic anemia because there is some icterus, mild splenomegaly, but how are we going to explain the hematuria in this child? And how are we going to explain these clinical features like significant knuckle pigmentation, ball tongue, and all these? So with this, when you look at the peripheral smear, it will clinch the diagnosis, that is hypersegmented neutrophil pointing towards B12 deficiency leading to pancytopenia. You can see platelets low, WBC low, hemoglobin low secondary to B12, as well as because of the bleeding hematuria that is happening. But one question that will come into mind is why this child is bleeding at 65,000. So presentation would have been different. Like, you would have walked into the clinic with easy fatigability, anemia, and then you notice pancytopenia, knuckle pigmentation with raised LDH, all these things. In these children, mild indirect hyperbilirubinemia is expected because these erythropoietic cells will have intramedullary hemolysis leading to indirect hyperbilirubinemia. Hence, that should not mislead you towards hemolytic anemia. Of course, we have to keep hemolytic anemia into the mind and then look at the peripheral picture carefully. But this is one of the differential when you see this kind of picture. So now going back to the question, why child black had a bleeding at 65,000, that is a moderate thrombocytopenia. You are not supposed to have hematuria. So with that question, when we sent the urine culture, so he had UTI. So it was B12 deficiency with UTI, with pancytopenia. So sometimes they can come with a complex way. But most important thing, as we discussed earlier, so looking at the clinical features are very important. So this is so far we have seen all different kinds of platelet disorders and clotting disorders and malignancies and even nutritional factors that leads to thrombocytopenia, and then with associated problems they can have bleeding. So this is one child who had without any platelet problem or coagulation problem or any other systemic problem, had a significant episodes of bleeding, which I want to share. This is 1.5-year girl born to non-consanguineous parents with history of bleeding from multiple sites. It's not a frank blood, it's a blood mixed with the fluid coming out, oozing from, sometimes oozing from eyes, sometimes oozing from mouth, at times from nose, sometimes from umbilicus. You can see the bleeding from umbilicus. It is clearly blood mixed with the fluid oozing out. So first of all, obviously we get the doubt, like, and her complete blood picture did not show any anemia despite of multiple episodes of bleeding, indicating that the blood loss is not significant. So it's predominantly fluid mixed that is causing the volume like this. So see, hemoglobin was normal, coagulation profile including factor 13 fibrinogen were normal, bleeding time, platelet function assay, everything were normal. And this child used to have intermittent hypertension, for which she has been investigated for all the causes of hypertension, as you can see, which has been listed down. All are normal. So then finally she got diagnosed. Initially, with looking at this nature of the bleed itself, we suspected hematidrosis, that is rupture of the capillaries in the sweat gland leading to fluid mixed, or in the mucous glands, either in the sweat gland or in the mucous gland, leading to fluid mixed blood that oozes out and then presents as a bleeding problem. So this is, the cause of hypertension, though it was not diagnosed, she has been diagnosed later as a hypertension secondary to autonomic nervous system dysfunction, because it's not a constant hypertension. She will get hypertension, she bleeds and goes into hypertension, and she stabilizes again after few hours after the initial supportive care without any antihypertensives in the beginning. So later she used to bleed almost every day with this kind of bleeds she used to have. So hypertension, bleeding, and then hypotension requiring multiple admissions, requiring on and off transfusion despite having all the blood parameters normal. However, finally got diagnosed as an autonomic nervous system dysfunction leading to hematidrosis. So to control ANS dysfunction, we have put her on medications. And then with 4 medications, now her once a day episode has reduced to once a month episodes. Like still she gets into episode, but parents are now quite very well, they know, they are aware of the problem, how to manage. So, and it happens usually once a month nowadays. So we have to be, and most of the times this kind of bleeding happens with the stress factors. Hepatitis is secondary to stress factors, but in this child it is because of ANS, because it happened in ANSD because of very young age. We suspected ANSD and put her on corresponding treatment, and she is fine now. So what are the take home messages? So taking a thorough history and good clinical examination, and question yourself whether it is acquired or inherited problem. And once you have done that, then investigate wherever it is required. For example, why I'm saying wherever it is required, some child, one of the child, like, I mean, many times we do see kids coming with epistaxis. So which will be unilateral, insignificant quantity, usually happens after nose picking, volume is insignificant, doesn't require any transfusion, no past history, no family history, no bleeding from other sides, then obviously we don't need to investigate them. We have to counsel them for the regular habits, like to stop nose picking, and then how to handle the episodes. So counseling is required in those kind of things. However, if you think that it is a significant acquired problem or any inherited problem, they require investigations in a differential that you have come after your initial history, clinical examination, and initial parameters like blood counts, and of course next PTA, PTT, and bleeding time. So all these, they require timely diagnosis and right management. For example, you are suspecting factor VIII deficiency, and then you don't have factor VIII level, you only have prolonged APTT, giving FFP alone will not suffice. So definitely you need to supplement adequate factor at very high concentration to control the IC bleed as well as to prevent further bleed in the same area. So timely diagnosis is very important in these children, and so that we can do the right management. Antenatal diagnosis in future pregnancies is very important, because many conditions, as we have seen, like autosomal recessive disorders, and family screening. For example, you have a factor VIII deficiency child or any other problems where you are suspecting inherited disorders, doing extended family screening is also recommended now to prevent the same kind of problem getting repeated in the same family. Thank you all. So managing these complex disorders, as we all know, it's teamwork.
Thank you, ma'am, for your lucid presentation. I request Dr. Gopal Singh to take over.
Good evening, sir. Good evening to all.
Dr. Gopal Singh.
Sir. Excellent presentation, madam. It's very useful for practitioner, especially those who are working in rural areas also, like in districts.
Thank you.
And with your case presentation, we can at least pick up few of the cases, and at least we'll suspect them early. And this, especially hemophilia cases, now we are getting regular hemophilia cases for transfusion at Nizamabad Medical College. We have a center here, and the factors are also available. We are giving them the best treatment possible here. As you said, we have to prevent the morbidity. That is, we should not allow them to go up to the knee joint replacement. So that's one thing what you have highlighted is it's useful for all of us, those who are seeing these patients in the early stages.
Yes,
so the thing is, now the factor is available everywhere. The only thing is we have to guide them. We have to send them to proper places where the treatment is available. And there are other NGOs giving support to these children. And we have a patient here. He's not, we can't say patient, but he's around a retired employee. So he has completed his 70s with this problem. So that's the only thing is what we, the thing is, the only thing is they have to maintain their factors and to avoid the possibilities, like whatever the damage or the morbidity. That's the only thing we have to highlight this.
Yes, sir. You have pointed out, you have brought up very important thing, that is hemophilia compared to West in our country, education level and then as well as the employment rate, all those things are less because there is no adequate factor supplementation. But now with availability of factors in many of the government centers at free of cost, even once it goes on to prophylactic treatment, they can lead near normal life, so that they can have a quality of life in the future. So absolutely right.
Thank you, madam. Over to Yashwant sir. Yashwant sir.
Hello, Dr. Gopal Singh.
Sir.
Dr. Gopal Singh, there are some few questions to be asked by some participants. Please,
Yes.
Yeah. Follow.
There are few questions in the chat box. So should we go ahead and take one by one?
Yes, madam. Yes, madam.
Yes.
Yes, Dr. Gopal Singh, please. Yeah.
Yes.
Dr. Siresha, madam.
Yeah. Tell me, sir. So it's a pre-operative management of hemophilia in minor or major surgeries. So that is the question. So it depends on the surgery, type of surgery. So the dictum now is like hemophilia child, if they require surgery, it is our problem to control the bleeding. So we have to achieve the hemostasis, and surgeon has to go ahead and do his job. So now, like luckily Hemophilia Federation of India, they supply free factor for all surgeries. However, one has to remember that once we do a heavy factor exposure during surgery, subsequently the chances of inhibitors are also high. However, if the child requires surgery and that is mandatory, in that case, we have to go ahead by supplementing the adequate factor. For example, for dental, you supplement 30%. For abdominal, you go ahead and control the level, maintain the factor around 60-70%. If it is CNS surgeries, you maintain around 100%. So these are kind of like, percentages we have to achieve by calculating the adequate percentage for the weight and going by the factor. And then we have to supplement the factor and go ahead with the surgery. And what is the best alternative to children with ITP not responding to steroid and IVIG is another question. So we have to, once again, even in ITP, the dictum is you have to treat the child. If the child has significant bleeding manifestations, one has to go ahead and start, depending on the need. We may have to go ahead and give IVIG, like CNS bleed or oral bleeds or mucosal bleeds. You go ahead and give IVIG, or if it is less than 10,000, you go ahead and give IVIG and parallelly start steroids to get the better increment. And of course, in those, you have to wait 5 to 7 days to see whether they are improving or not. If they are not improving and then child still has bleeding manifestations, one has to go ahead and add TPO analogs. Now, current recommendation in 2019 says that you have to go ahead and give TPO analogs like eltrombopag or romiplastim. Earlier, it was like a rituximab, but now TPO analogs are the recommendation after IVIG and steroids.
Madam, one more question is from Dr. Arjun, madam. How frequently platelet count to be done in case of both acute and chronic ITP? Because the labs are reporting frequent thrombocytopenia and there is no clinical dengue possibility.
So yes, yeah. So if we have a ITP child who has come with the bleeding manifestations, you started on treatment. Generally, we advise them to check the increment at least after 3 days. So after 3 days, if there is increment, you discharge them on medications, oral medications. If there is an adequate increment, like it, sometimes some of them, it goes into lakhs from 10-20%. So in those children, once it goes into lakhs, while they are on at the end of the tapering, we call them. That is after 3 weeks, we call them for next count checkup, provided in between child is stable. But if the increment is inadequate, we do go ahead and call them after a week to see that they are further responding and then count is going up. And once you achieve at the end of steroid, count is normal, no significant decrease in the trend, then you can leave them for a month. So third count you may be doing up, third, fourth count you may be doing after a month. Then gradually you have to reduce the number of CBPs, like once in 2 months, for a few months, and then you can stop. There are no guidelines how frequently you have to check. But once they come to normal count, there is no indication to do frequent counting. Maybe like after 2 months or 4 months you can do them in the follow-up. Like you can reduce the interval between, you can increase the interval between the testing. In case of chronic ITP, it depends on the nature of the bleeding. So if the child is in the bleeding manifestation, so even in chronic ITPs, they can suddenly come with oral bleeding. Right now, we have a child who has come with significant oral bleeding in the ward, who is being a chronic ITP. So they can do that at times. Then you have to go ahead and give medications to which they have responded in the beginning. That is, it could be steroid, it could be IVIG. In the acute phase, these two are the things which will improve the count immediately. And then ongoing medications like second line medications like azathioprine, dapsone, these things will be ongoing in the background in a severe thrombocytopenia. So when they come with acute bleeding manifestations, significant bleeding manifestations, you may have to rescue them again with the steroids or IVIG. But second line drugs you have to, and that will be transient. You will be giving transient course, and then second line medications will be ongoing. So until you control the bleeding, you may want to do frequent check. After you control the bleeding, then once in 2 months, once in 4 months, we call them and then check the blood counts.
Okay, madam. One more question from Dr. Lakshman. Is there any role of immunomodulators, madam, in ITP treatment, like levamisole?
So
role of immunomodulators in ITP
yeah, sir,
treatment.
definitely there is a role. Like all these medications like azathioprine, dapsone, they all, for example, if you take azathioprine through T cells, it works through T cells. It modulates the T cell function and then further reduce, which in turn controls the B cell, and hence it will control the autoantibody production. So azathioprine, drugs like dapsone, danazole, even one can use the drugs, medications like vincristine, or even cyclophosphamide is an immunomodulator. So one can go for once a month or once in 3 weeks cyclophosphamide also. But commonly used medications are azathioprine and dapsone. They are cheap and ineffective. But now current recommendation is TPO analogs, even in acute episode where they are not responding to steroids and IVIG, or even in chronic ITPs who are having significant bleeding manifestations. However, TPO analogs are expensive, so we have to choose like who can go for it and then advise accordingly. We can't recommend to everyone.
Thank you, madam. One more question is for what is the vaccine to be avoided or while giving recombinant hemophilia factors?
So vaccine to be avoided during hemophilia A. Sorry, I didn't get it.
Ma'am, the question is, are vaccination to be avoided while giving the recombinant factors? Can we give or we have to stop because going on?
Yeah, there is no recommendation that if you are giving on factor therapy, for example, you may be on, of course, in the acute phase of bleeding, you don't give them vaccine at that time. If they're on prophylaxis, or even if they're not on prophylaxis, when the schedule is due, we do recommend them to go ahead and take the vaccination. So we don't stop that. But only thing is, technique of vaccination is different. Like, subcutaneous technique we advise in severe cases. So especially who are not on prophylaxis, so we advise a different technique.
What is your advice by Dr. Usha Rani? Madam questions that in ITP, in case if you cannot give steroids or IVIG, what is the best?
Yeah, so it depends on whether child is bleeding or not. For example, we have managed few kids who has come with 25 to 30,000 count with skin bleeding manifestations, which are ongoing for months, for longer periods without any treatment. But if the child has less than 15-20,000 and with significant bleeding manifestations, either IVIG or steroid, definitely we have to go for it. And if that is not working, one can go ahead and start TPO analogs. In the past, we have used rituximab also, even in acute phase for a couple of kids, and then it showed response. However, rituximab takes time, for some time. So during that period, you have to go ahead and continue at least, the low dose of steroid, even if they are showing some effect. Steroid not only reduces autoantibodies, it also stabilizes the membrane. So hence, the bleeding manifestations are going to be less. On one hand, steroid can cause skin laxity, thinning of the skin, but on the other hand, it also has vascular stabilization action. So going by that, though the count is not incrementing, in the acute phase, when you are waiting for other drug to work like TPO analogs, you can continue, go ahead and continue low dose of steroids. So that will control the bleeding manifestations. So, or if you are waiting for, you absolutely, if it is contraindicated for some reason, you can go ahead and control the bleeding with simple drugs like tranexamic acid, and then you can give TPO analogs. However, if bleeding is significant, tranexamic acid doesn't work, so you have to go ahead and give IVIG and then give other medications.
But one more question from Dr. Chakrapani, madam. What is the earliest age you diagnose hemophilia in our clinical practice? What is the earlier age to diagnose hemophilia case?
As we all know, in the past, like they used to come in a toddler age group or little bigger age group with the knee bleeds, and then we used to diagnose hemophilia. But nowadays, parents are more observant, or whatever the reason, we are looking at infants. Lot of infants getting diagnosed in the infancy itself. They present with the bruising while crawling, or they child or something like that with the at the pressure point. That, or when a child starts walking and then falls and then injures the gums or lips, they start continuously bleeding. So these are the scenarios what we notice, like bruises are bleeding from lips post injury. Early infancy or later infancy are also, like, a lot of hemophilias are getting diagnosed.
Madam, one more question for Dr. Lakshman. What is the percentage of childhood ITP will go into adult ITP? And another question is, what is the when the splenectomy is indicated in chronic ITP?
Percentage of childhood ITP going into adult ITP is very less. So if you look at what is the, first of all, we need to see what is the incidence of chronic ITP. 1/3 of them can have long-term problems with the ongoing ITP. It may not be problem like bleeding manifestations. They come suddenly, like at adolescent age or like young adults. They come and say, as a child I had ITP, and then I don't have any bleeding manifestations. I'm not on any medications. And then we have seen, like, one pregnant lady today in the clinic. So who has come with, like, as a child I had ITP. So at times, you do see that. So whoever goes into chronic ITP, 1/3 of them can go into long-term chronic ITPs. Remaining of them, like, they do respond at the end of 1 year, 2 years, or 4 years. If you are not responding by 4-5 years, generally you can go into chronic ITP. But not all of them will have bleeding manifestations. One. And then splenectomy is the second question. So splenectomy, definitely now the current recommendation up to 1 year, you don't consider splenectomy. One is age indication. So any child who is less than 5 years, even if the ITP crosses beyond 1 year, you don't consider. You have to let the child cross 5 years. After 5 years, like bigger child who is beyond 5 years age, having ITP for more than 1 year with significant bleeding manifestations, one can go for splenectomy after vaccination, giving 1 month gap, then you can go for splenectomy. But we need to explain to parents that the efficacy of splenectomy is 75 to 80%. So despite of going for surgical intervention, we may fail 20% of the times. We need to explain to the parents about that and then take them into splenectomy. But now, before splenectomy, you have options like rituximab and TPO analogs.
Thank you, madam. Thank you. You have answered all the questions of our audience, and it's very excellent interactive session for all of us.
Ma'am, what is your advice? What is your advice regarding contact sports for patients of hemophilia and
So definitely for severe hemophilia, we always tell them not to go for any contact sports. Even that applies for moderate hemophilia. And if they are on prophylaxis, they can do simple sports like swimming, or even otherwise like sports are recommended for these children. So definitely contact sports needs to be avoided. However, if you are on factor, some limited activities, see contact sports like rugby, football has to be strictly no. But other sports, if you are on prophylaxis, one can go ahead and do that.
Thank you, madam. Thank you. There are so many wishes from the Daivadinam sir and Dr. Nili Ramachandra and Chandramouli sir for your excellent presentation. And now it's a time for our Yashwant sir to say a few words. Dr. Yashwant sir.
I thank. She is an alumnus of Andhra Medical College, done her FNB from Rainbow Hospital. She is now a junior consultant along with Dr. Sirisha Rani. We welcome her here for this program. And in fact, I thank all the participants. Initial disturbance in the first forefront. I'm sorry for that. And I thank Madam for having accepted and came up with the talk immediately within 2 days' time. I thank both Sandhya Madam and Sirisha Madam. Over to Dr. Lakshman. Dr. Lakshman sir.
అన్మ్యూట్ చేయండి సార్, అన్మ్యూట్ చేయండి. లక్ష్మణ్ సార్
చేశాను, అన్మ్యూట్ చేశాను.
లక్ష్మణ్
లక్ష్మణ్
సార్
సార్
అన్మ్యూట్ లేదు.
Hello,
Right,
am I
right.
audible?
Yeah, now.
Yeah, thank you very much,
Yeah.
Dr. Sandhya madam and Dr. Sirisha madam. Yeah, excellent presentation, and around 15 case presentations by Dr. Sirisha madam has almost covered the bleeding disorders. And thank you very much again, once again. Thank you all the participants.
Sir, shall we close the session, sir?
Yeah.
Yashwant sir.
Yes, sir.
Any
Everyone,
Yeah.
please
Sir,
leave the meeting.
So thank
We
you,
have
sir.
next webinar on Monday.
same time, sir. 6 to
Monday, yeah.
7.
Nephrology talk by Dr. Mehul Shah and
Timing,
Vijay
sir,
Kiran.
timing?
Same 6 to 7.
Okay, sir. Okay.
6 to 7. On Tuesday, we have Dr. Murki Srinivas and Dr. Sriram talking on failure to thrive, COVID, practice in COVID, present, past, and future. With faculty from Hyderabad, Dr. Sanjay Srirampur will moderate. Dr. Mahendra Reddy is one of the panelists. Dr. Kanchala Ramesh is going to be one of, and Dr. Satish Tiwari, who is a medical legal expert, will be joining us.
Okay.
And will shortly we have in line one pediatric surgery topic which we'll be disclosing. Thank you one and all for joining us and making this program a successful. Thank you. Thank you, ma'am.
Shall we leave, sir? Thank you.
Yeah.